100
Yes,
students. Yeah. What? Do we expect more to join, or should I start?
so you can start.
Okay. All right. So you can see the PowerPoint, right? Okay. So please confirm that you can see the PowerPoint. So I shall begin the
Yes,
lecture.
sir.
Okay. So
Yes, sir, we can hear.
yeah. So basically, in the last exercise, we have discussed regarding how to prescribe, write a prescription, and how to communicate that prescription to the patient. And now in this exercise, what we are going to do is we are going to choose the drug, how to choose a particular drug that you're going to prescribe for a given patient or a condition. And the name of this exercise is to prepare and explain a list of P drug for a given case or condition. Now, what does P drug means? P drug basically it's a personal drug or a priority drug or a practical drug. We say that this is a drug that, for example, if you're sitting in an OPD, you're seeing 40 to around 80 patients in an OPD in a span of 2 to 3 hours, and every time it's not possible for you to, to think over it and to prescribe a particular drug which is best for that patient. So what we have emerged, the concept has emerged that you tend to prescribe a particular drug that you feel is would be appropriate for your patients, for similar patients, and that you keep on prescribing more frequently. So such drug which with which you are familiar or which you tend to prescribe more, you have more knowledge about that particular drug also, and you are more averse with the dosage, with the side effect and mechanism and the expected outcome with that particular drug also. So such drug is known as P drug or P medicine, right? Now, why it is important? Why not that there are certain guidelines are there, there are essential drug list is there, there are expert opinions. Why not you just pick any drug which they are saying? Why should you choose a particular drug for yourself rather than copy pasting from someone guidelines from the US FDA or WHO? Is because eventually it is your responsibility. The patient is your responsibility, and whatever you prescribe is your responsibility. Secondly, the guidelines may change. Maybe the guidelines are recommending a particular drug, but that particular drug is contraindicated in your patient. Then what to do? Then, for example, the guidelines are prescribing a particular drug that is expensive or that is not suitable in your setting. You cannot afford that kind of a drug in your setting. Then what to do? So that's why in the time, space, and a person, the drug might differ, right? So you have, and secondly, if you don't understand the drug per se, then what would happen that you would be encountering many your seniors or maybe the pharmaceutical company representative would be coming and giving you a lot of information. Now please understand that any new drug is not the best drug, right? So if you are aware that what particular drug you are prescribing, and then the information that you are getting about the new drug, you can assess whether this is efficacious enough, whether this is suitable enough, whether it has side effects which are lesser or which are more favorable as compared to the drug that I am prescribing more frequently. So efficacy, safety, suitability, and the cost of that drug. So these are the four parameters with which we usually tend to gauge. Now, now we are applying these parameters subconscious at the subconscious level whenever we are prescribing. Now, in this exercise, we are going to just formulate this, that how we actually go on doing it, and we will try to find a P drug for a particular case or condition. And what we expect is that for each chapter, like if you can say that if you're learning about antihypertensives, you must have seen there are so many groups. There are beta blocker, there's ACE inhibitor, and among those groups there are many me too drugs, like 10 15 drugs. It's not possible for any person to remember all the drugs for a particular condition, but it is possible to know everything about one particular drug, right, for a given condition. And what is the advantage of that is that your experience with that drug would grow, right? You would know everything about the dosage. Maybe as you keep on prescribing, you tend to get more aware about the side effects, how efficacious it is, what are the dosage forms it has. So that experience also improve, and this not only benefits you but also to the patient, because you know the most thing about that drug that you're prescribing. So that is the concept from where the P drug has emerged. Now the P drug you can choose maybe from a guideline or maybe from an essential drug list, but eventually it is your decision that you're prescribing at a particular drug, not a recommendation by the US FDA or the WHO or maybe your national guidelines. Now we'll start with this practical exercise. So in this exercise, it's these are basically practical exercises. So you must be aware that since just because it's an online, it doesn't mean that it's just a lecture. So as much as you participate, you will tend to learn more. And secondly, it's an important concept. You won't find it anywhere written in your in your textbooks. So best if you focus and if you try to understand and if you try to participate, you will be able to learn more. Right. Please mute your mic. Yeah. Can you please mute your mic? You have to mute all of you. Okay. So please message me if you're having any trouble. Now, the coming to the, as I said, that whenever a patient comes to you with a problem, you being a doctor, you will take a history, you will perform a clinical examination and ask for a few investigation, and eventually you arrive as a diagnosis, right? So this is the first step in before we prescribe any particular drug. This is the first step toward the rational prescribing, that you know you have a diagnosis or you have a working diagnosis at least. Now, based on that diagnosis, for example, if the patient is having a cough, right? So based on that diagnosis, you try to achieve what is your therapeutic objective. Whether the therapeutic objective is to suppress the cough, whether the therapeutic objective is maybe the patient is having underlying tuberculosis, you have to treat that, right? Or maybe you have both, right? You want to have you have to suppress the cough as well as you have to treat the underlying tuberculosis or the underlying cause, right? So you define the therapeutic objective, what you want to achieve with your therapy, and based on the objective that you have set up for that particular patient, then you select an appropriate treatment. So for a cough, it could be an antitussive, say, maybe syrup, or it could be maybe an advice that he takes steam inhalation because it's a post-viral cough. It doesn't require any kind of medication. Or maybe it's a cough that is related to the tuberculosis, so that you start the patient on the ATT or the anti-tubercular treatment, right? And this appropriate treatment is then will fulfill your therapeutic objective, which is that you want the patient cough to be improved, or you want the disease to be taken care of. So this is the first step. So these are the steps in the rational prescribing. Now, as I said, that it is not just the P drug, it can also be the P treatment. P treatment is your personal treatment. So the treatment could not necessarily be prescription of a medication. It could be an advice or a non-medical treatment. It could be a referral that you feel that you are not equipped enough to handle the patient here and it requires a specialist opinion, right? Or could be a combination of both. Maybe you are giving an advice like a COPD patient has come, you are advising to quit smoking, and at the same time you are prescribing him any maybe any inhaler, maybe salbutamol or ipratropium inhalers, and also so it could be a combination of both also. So such a treatment that you choose for that patient is also your personal treatment, because again it can vary between the two individuals. Also your patients could be two different. Maybe there is one smoker, other is not smoker, like someone is having COPD, other is having asthma, right? Again the treatment would differ. Secondly, from you and your colleagues, you two are also different. You are interpreting a particular information in your own way. Your drug of choice could be, or your P drug could differ from the other one also, right? Maybe someone is prescribing ipratropium bromide, other one would try that I would prefer tiotropium. They say, although it is slightly more expensive, it is giving a better result to me and I'm more comfortable with that, or whatever, right? So these can vary. Again, the four pillars, as I would mention again and again, that is, it would be efficacy, safety. These are the two important pillars, but again, the two things that are more important are suitability. Whether these drugs are suitable for that patient, maybe that particular drug is causing side effect or is contraindicated that patient, or the patient has tried and then failed on therapy or that particular medication, right? So maybe that is not suitable for that particular patient. Then the cost wise also, especially in the chronic therapies, if you have to, you know that a patient has to be kept on a particular medication or advice for a long duration, then the cost again becomes important. Now, coming to that, how you select the pre-treatment also, right? As I said, that doctors, you tend to make an inventory of choices of the treatment that is available. Like I've said, that there could be advice, could be non-medical treatment, could be referral and whatever, and or could be that you are combining any of these advices. So these are the 3 or 4 option. Could be fifth option also for you, right? And then you on the basis of these 4 pillars, whether this is efficacious, whether the advice with the therapy would be better, or whether just quitting the smoking would be better, is good enough for this patient, or adding in an inhaler is also needed, or maybe a referral is also needed, or maybe a combination of both. You give a primary therapy and then you send the patient to the expert, right? So depending on that, the efficacy of your treatment, how safe it is for the patient, and how suitable it is. Suppose a patient has come that he has already tried 3 different doctors and his blood pressure has still been not been controlled, right? You see that the problem with the patient is not efficacy or the safety of the medication. It is that the patient is not compliant enough, right? Patient doesn't understand that he has to take this medication for long duration. It's not perhaps a lifetime also, right? So then again, then advice would be sufficient in that scenario. Then there could be that the cost is something that is deterring the patient to purchase that medication again and again, right? So you switch on to a therapy which is less costly, so that the patient is more compliant on it, right? Or maybe certain lifestyle modification that would be sufficient to handle this mild hypertension, right? The patient, it won't cost patient his money, right? So based on this efficacy, safety, and suitability and the cost, you decide the treatment, not just based on the efficacy and how safe a drug is, right? But how safe and efficacious it is for that patient, that a cost is, that is important, right? So the treatment, that whatever that you choose or the doctor selects for that individual patient based on these parameters is known as P treatment, right? This is P treatment. As I said, that the P treatment could include a drug, but it is not necessary that it could include a drug. However, if you choose a drug, if you select a medicine to treat this patient, then such drug would be known as P drug or the P medicine, right? And I said that the P stand for your personal or the priority or something that you're practically using. Okay, that drug, right? The personal, priority, and practical. Please remember that if possible, just click the pictures also, a few important concepts, because you need to write this in your practical files, because you might be asked about this drug, and especially the case scenarios you might be asked and how to deal with it, right? In your practicals also. Now coming to this exercise, what we have to do in this exercise is we have to prepare and explain a list of P drug to for a given case or condition. So this would be a model exercise, and after this 1 hour, you would be divided in different groups, and we would have 2 or 3 cases based on the different conditions where you would be choosing the P drug. So please listen carefully during this discussion so that you would be equipped enough to answer in the discussion classes. Now, what is the learning objective that we have kept for this class is that you know that the rational prescribing of you have to learn the rational prescribing of selecting an appropriate treatment for a patient based on these criteria, and as I mentioned, right? How to rationally prescribe a selected drug for a patient. Right? And we'll also discuss what are the different steps in rational prescribing. Right? As I've already mentioned, that it starts with defining a diagnosis, or at least a working diagnosis should be there. Then the role of pharmacokinetics in determining the suitability of different formulation of a medicine. So it's not just the mechanism, it's not just the safety, it is also the pharmacokinetics. Perhaps a drug which is, for example, why in diabetes, if you say that we have insulin, we know is the best drug, but it is not the most suitable drug to be used, because it is difficult to administer, the patient feel pain, or the patient is not comfortable with it. So although insulin is the best drug, that could be because diabetes is because of deficiency of insulin, right? Mellitus. So but it is not suitable for that patient. That's why we prefer oral formulation, right? So pharmacokinetics, something that is absorbed orally, is being preferred, but the insulin is not absorbed orally. We don't have any inhalation formulation as of now. So again, it's not suitable for that particular condition. So pharmacokinetics itself is also important for the choice or suitability of a condition, of a particular medication. Now, how we are going to do about is that we'll be giving you a clinical problem. In this class, we'll be discussing on the angina pectoris, and we'll be selecting P medicine, P treatment, and the P medicine, and then eventually prescribing and how to communicate. This part we have also already dealt with in detail in the last practical session also, that how to write a prescription and how to communicate it to the particular patient, right? So as I said that we have categorize different aspect in that there could be certain information, there could be certain advices, or there could be certain warning, right? So these are the 2 or 3 things that we expect you to communicate to the patient. Okay? So information related to that drug, any instruction you want, the how to that drug is to be taken, and then any instruction or advice, whatever, and then the warning, if any warning is there. So as I said that we do not want to bombard the patient with all the knowledge that we have regarding that particular drug or treatment. It is that only the essential and the relevant information is to be taken, which you feel would be important for the patient while he's been put on that medication. And eventually, while you're closing that session, you have to ask whether the patient, because these are again, as I said, the soft skills or the communication etiquettes that we have learned in the last class, that you have to ask if the patient wants to know anything else or if something that is not clear, and please ask him to summarize so that he actually hasn't nodded, he has understood few things, right? And as I've already mentioned, you have to write these exercises in your practical file without fail. It is important that you do that because you won't find these exercises anywhere, and you would definitely be asked questions on these exercises, right? Now we coming to our therapeutic guidelines, or how to rationally prescribe a P drug, or how to go about rational prescribing. So whenever a patient comes to you, it comes with a problem that he's having maybe headache, or he's having blurred vision, or he's having chest pain. So you first of all, you just take history, examine the patient, order few investigation, and then you arrive at a diagnosis. Once you have arrived at a diagnosis, we define the therapeutic objective. It is the objective we want to achieve. For example, if the patient is having pain, then we want to alleviate that pain. So that is our therapeutic objective. And now how to relieve that pain is the choice of treatment we might say. For example, if it is a pain because of injury or whatever, then again your P treatment would be surgical if it is because of fracture. Right? If it is a chronic pain, maybe myalgia or a headache or a migraine, then again your advice would be maybe an NSAID, or maybe if it is a chronic problem, then maybe it would not only an NSAID but something else also in combination. So you choose a P treatment. Treatment could be advised, or maybe if the, as I said, if the patient is having a fracture which would require surgery, it would be a referral also, right? So you identify what is the best treatment for that patient, and that treatment is known as P treatment, as we have already mentioned, right? Now, out of that, if that P treatment involves that you want to give a drug now for that patient, maybe the patient is having headache because of hypertension, and now you have decided that the patient is a case of essential hypertension, and now we have to give a particular medication for this patient. Perhaps it could be an advice also. If it is a mild hypertension, you say that the patient might go for dietary restriction, lifestyle modification plus salt restriction. That is sufficient for this patient. But perhaps this patient is not doing well on that, or the patient is having severe hypertension, then automatically we have to start the pharmacotherapy for that patient, and we have to select a particular drug. Right now, as we know that there could be different groups of drug that are there, we have to first select a particular group. Maybe the patient would require a beta blocker or an ACE inhibitor, maybe a calcium channel blocker or a diaryrotin. Right now, if you select that I have to give the patient a beta blocker, then which beta blocker? Right, maybe an atenolol, cardioselective, non-selective, which one? Again, from that group of beta blocker, we'll select one particular drug. For example, you select an atenolol, right? And how you are selecting that, it has to have some basis, right? It cannot be just because you feel like that. Then, because we are obviously we are working that something out in your brain that this is more efficacious, this is more cardioselective, this is more suitable, right? But when we are doing an exercise, we want it to be done objectively. So not so that you don't miss out an important aspect. Cost is also important. Suitability is also important. Maybe if a drug is given once a day, it would be more suitable for this patient perhaps than giving twice a day. Right? But if the suitability has been achieved, but the cost is disproportionate to the benefit it is giving, then again it would be a deterrent, right? So apart from efficacy, because maybe you feel that all the cardioselective beta blocker are similar, they have similar efficacy, similar safety, then the onus goes on the suitability and the cost of that particular therapy or a particular agent, right? So once you select a P treatment, you select a P group, drug of group from which you want to select a particular drug. Then you select a particular drug, and once you have selected a particular drug, you start the treatment. You prescribe that drug to the patient, right? And then communicate henceforth what are the information, instruction, and then the warning that we have already covered in the last lecture. Now, coming to the problem. Now, on the basis of this problem, we will be going on to select a particular P drug for this patient. As now, a 55-year-old male has come to the medical emergency with the complaints that during the last month he has had attacks of suffocating chest pain, which begins during physical labor and disappears quickly after he rests. And he used to be a smoker, but has not smoked for the last 4 years. The physical examination reveals that the blood pressure is 138 by 84 mmHg. The pulse rate is 88 per minute and is regular. Body weight is 65 kg. There was no other abnormality. You ask for a few investigations like ECG and all are done, and you make a diagnosis of stable angina pectoris. So there's a patient who says that he has attacks of suffocating chest pains in the last 1 month, and he also had a history of smoking also. No other abnormality you found on physical examination or the investigation that you have ordered, and you have now reached to a working diagnosis that it is a stable angina pectoris. And now you have to choose a particular P drug or a P treatment for this patient, and you have to prescribe it to the patient and communicate the same to the patient, right? So there are 3 jobs to be done. The first one is choosing the P treatment or the P drug that we would be focusing in this exercise, and then how to write a prescription and how to communicate that we have already did, but so we'll be briefly touching upon it. Now, as I said, so the problem, we know the problem. The patient problem is that patient is having chest pains, right? Frequent chest pains in the last 1 month, right? So diagnosis which we have arrived is stable angina pectoris, right? So this is our diagnosis. Now, what we want to achieve for this patient is we want to stop an attack as soon as he has that attack, right? So whenever he's having that attack, we have to ensure that that is aborted as early, and then we have to also prevent that attack if it is from happening, right? So that would be our objective. So what we want to do is, our primary objective here would be to stop an attack as soon as it is starting, right? Then choosing a treatment for a particular therapeutic objective. Now we have to choose a particular treatment. Though आपके objective थे A and B, right? So we are now focusing on how to choose a particular drug. So we have to apply the same things for the B part also. But we are focusing on the part A, how to stop an attack as soon as the start of angina. Right? Now we have to choose a treatment for the therapeutic objective A, which is to stop an attack as soon as it starts. Right? So what would be the treatment would be, we have to see whether it requires medication or just an advice. We know that angina pectoris, it would require some medication to abort, and advice won't be sufficient enough, right? So for that advice, so it would be a medical treatment. Now we know that there are different groups of drugs that could be prescribed, right? So we have to choose a P group, which group of medication, whether it is a nitrate, whether it is a beta blocker, whether it's a calcium channel blocker, or we have the newer therapies, which one to select, which group to be selected for this particular patient. And if we select a group first, then we have, for example, if we select a beta blocker or a nitrate, then which one? So then we'll focus on the which particular drug of that particular group would be prescribe for this patient. And once we have arrived or we have made our consensus that this is the drug that would be most suitable or the rationally most equipped drug for this particular patient, we'll prescribe it and write a prescription, give the information, instruction and warning related to that particular drug that we are prescribing. And then we'll eventually monitor and see whether our therapeutic objective has been achieved or not. If it is not achieved, again, we'll revise it in our subsequent consultation. Now, as I say that, and now just briefly about our problem that angina pectoris is because, as we understand, is lack of oxygen to the myocardium. Okay. So, there would be a decrease in the oxygen demand, or there would be a decreased oxygen demand, or the increased oxygen supply is something that we want to achieve for this particular patient. Now, what can we do with in this case? Either we can give an advice that asks the patient to rest, but it won't be so. But whenever he is exerting, even minimal exertion will lead to these symptoms. Then there could be non-medicine advice, could be something else if you want to prescribe this patient. Then medical advice or the medicine we can choose, like as I mentioned, that there could be nitrate, beta blocker, calcium channel blocker, or the potassium channel opener, and newer drugs like metabolic modulators are also there. Then you say that perhaps you are not comfortable treating with this patient, so you or the patient symptoms are not getting treated with your medication. Then you refer the patient to the cardiologist, right? Or maybe a combination of the treatment. You advise certain lifestyle modification, you advise rest, and with that you advise medication also, right? So these could be the various P treatment option that we have for this patient. Now, as I said, that this is how we will be making an inventory of any P group per se. So whenever we are selecting as an, we have to define the diagnosis. We have to specify the therapeutic objective we want to achieve. Like in this case, we want to relieve the pain, and we as soon as it begins, right? And during the acute attack. Then we have to make an inventory of effective P group. Now the group is, there could be different drug groups that are there, and for each group we have to identify how efficacious it is, how safe it is relatively to the other, how suitable it is for the different patient, and what are the various costs involved, right, with this kind of a therapy. Okay. So we have to choose an effective group, P group, for this particular patient. So how we are going to do that is, for example, this is the way, right? For example, if we say that efficacy, there are 4 criteria that we have to discuss. One is the efficacy, then the safety, then the suitability, and then the cost. Now coming to the efficacy, if we say that how efficacious these 4 groups or 5 groups are, we have different groups like nitrates. We know beta blocker, calcium channel blocker, potassium channel blocker, metabolic modulators, and certain other drugs are also there, like your ivabradine, right? So there are other drugs also, like ranazoline and all that. So we'll see how they are working. Now we know that nitrates, how they are helping in angina is they are decreasing the preload, and they are also working on decreasing the afterload. So that's why providing rest to the heart, and hence the pain of angina is relieved. You know, beta blockers, they are decreasing the contractility of heart, so the cardiac work is reduced, its heart rate is reduced, and hence the oxygen demand is reduced, and again they are helpful. Then calcium channel blocker, again essentially acting through this same way as the beta blocker, decreasing the contractility of the heart and decreasing the heart rate per se. Also afterload reduction because of the arterial dilation that would eventually happen. Right? Then we have potassium channel opener. They are essentially similar to nitrate. They are veno and vasodilators, but less efficacious as compared to the nitrate, right? Then we have certain metabolic modulator. They are acting through fatty acid metabolism inhibition and all that. So their primary work is that. So usually they are used as an add-on therapies. There could be certain other drugs like ranazoline and all, which are decreasing the contractility of the heart also. So they are miscellaneous drugs. So if you can see out of this, we see that these 3 drugs, nitrate, beta blocker, and calcium channel blocker, appears to be the most efficacious for treatment of angina, right? So these 3 drugs, the nitrates, they are reducing preload, afterload, and the beta blockers especially are reducing afterload as well as the contractility of the heart also. So these are our 3 efficacious groups. If I go in more detail about this, then we will see that not only this, we have to understand more things about the pharmacokinetics also, and how they are not only efficacious but how safe they are and how suitable they are for different patients. For example, in nitrate, if you see, we know that they are efficacious now, right? but then we have to see how safe they are. We understand they have, because of vasodilatory effect, they have flushing and headaches, and maybe a tachycardia could happen, right? So that is one. They have a slight incidence, perhaps the nitrate tolerance or maybe nitrate poisoning can occur if you're taking long lasting oral dosages or frequent dosages are there. So there are side effects, but they are tolerable. Flushing, headaches, and maybe tachycardia because of vasodilation. Then contraindication, there are certain contraindications. If the patient is having a hypotension, if the patient is having a cardiac failure, then these drugs will be automatically excluded for these patients. Now, very briefly about the pharmacokinetics, we know that they have high first pass metabolism. So their absorption, especially if you're giving orally, it would be unpredictable. But but the advantage is that we have them in different forms are available, as injections, sublingual tablets are there, and the oromucosal spray is there. Right. So we have other options apart from the oral, because orally we cannot give it as a unpredictable metabolism, so might not be that efficacious. Now coming to our different other group, the beta blockers. It is again efficacious, decreasing contractility and the heart rate, but there are certain problems with this group is that again they can lead to hypotension. Again, maybe because of if the patient is in acute CHF, then this would further make it worse also. So they would be contraindicated if the patient is hypotensive or having a CHF, right? Or having any block, maybe bradycardia due to AV block and all. So again, this would be not suitable. But and there are certain contraindications also with the beta blocker, as we know that asthma and diabetes, and because of hypoglycemia and all that, it masks the hypoglycemia and it can make your asthma worse. So there are certain contraindications associated with it. But if we go into the pharmacokinetics, we say that they are well absorbed orally, right? And they are lipophilic, they'll grow in cross the blood-brain barrier also. And but the problem with this is that we have, for fast acting, what we have is that because whenever there is an acute condition, what we want is that we want fast action, right? Fast action in nitrate, we have injection, sublingual tablet, and a spray, right? For fast action, beta blocker oral route would take a bit longer time to act, right? But if the patient is having acute angina pain, we want to relieve it as soon as possible. So the fast acting dosage that would be available with beta blocker is injection only. So it won't be a sublingual tablet, won't be a nasal spray, right? And the oral would tablet would take a lot of time to happen, because if you will see the mechanism how which it is at. Now same goes with the calcium channel blocker. Again, it's a similar way. It reduces the after load also, and also the heart contractility. There would be similar side effect, like mix of side effect rather of beta blocker and the your nitrates. There could be tachycardia, then hypotension. They won't be able to use in CHF and hypotension, and maybe if there's AV block. Again, the fast acting dosage that we have is not a sublingual tablet or a nasal spray, it is injection. Now, of all, if you can say that they are all efficacious enough, right? Safety is more or less similar, right? More or less similar. Then suitability, if you can say that nitrate can be taken sublingually or by the nasal spray apart from injection, because a patient might be having angina attack at home also, while he's somewhere at work also, right? So an injection is not, maybe the patient won't be conversant enough to inject himself, right? It's not possible for anyone to inject himself, right? And especially a lay patient, and especially if he's having an angina attack, or finding a person who can inject him, right? So the sublingual or the nasal spray appears to be more suitable as compared to the injection. And in the beta blocker and calcium channel blocker, both are equally efficacious even if we consider, then their fast effect can only be achieved if we are injecting them. So again, it's not that suitable for particular patient, right? Because angina can happen anytime, and he might not have access to injection, or maybe a person who can inject that particular drug, but he can put that drug sublingually or can use a nasal spray at any time, right? Whenever he feels that he's starting to have an angina pain, and can abort the problem, this pain of angina. Now, coming similarly, if you can see other drugs that are there, because if you see that there could be new drugs also coming every day, every other day, every other year, you would be having new information, new drug. But when every time you have to compare these new drugs also based on the efficacy, safety, suitability, and cost of the existing therapies, right? So again, as I said, the potassium channel blocker, again vasodilatory are there. If you see, the side effects are similar, but as we have already found that efficacy of these drugs are not as good as the nitrates or the beta blocker or the calcium channel blocker, right? But you can compare these things also, that what are their side effects and how suitable they are, right? So these are mostly these drugs, as we know, that potassium channel openers, or be it metabolic modulators like ranazoline or ivabradine, or these kind of drugs. So these are mostly used as an add-on therapy. They are not used as first-line therapy per se. Now, now what we can conclude is that from our group per se, right? See that nitrate, beta blocker, calcium channel blocker, these are the three drugs which are more efficacious. If you can say the safety wise, all have the similar kind of side effect. Maybe some are vasodilatory or some are decreasing the contractility of the heart. So safety profile is more or less, the side effect profile are more or less similar, right? Efficacy, nitrate, beta blocker, calcium channel blocker has equal efficacy almost. Safety we see is similar in across the group. Suitability, as we have found that since most of these are beta blocker and calcium channel blocker, they are used as, can be used only in the form of injection if we want a fast action. We know that metabolic modulators, potassium channels, these again won't be that efficacious, and secondly they can be given orally only. There no sublingual or no sprays are available for them. But for nitrate, it cannot be given orally, but it has a faster mode of action, not only injection, but in addition we have sublingual tablets and also nasal spray, which can be easily used by the patient, right, to achieve our therapeutic objective, which is to relieve the pain. Then again, as far as the cost goes, beta blockers, as I said, that the cost could be variable. They could be cardioselective, which are more expensive. They could be cheaper drugs also, right? Same with the calcium channel blocker. Most of these new drug metabolic modulators and all these are expensive drug. Again, nitrates is relatively cheaper drug, right? We'll see how we have gone through it. Okay, why they are cheaper? Which of these drugs are cheaper? If you can see that the nitrates, they are one of the oldest drug, and it's cost around only, I think, 1 or 2 rupees per 3 tablets. So if we can see the efficacy and suitability, so clear winner is nitrate, right? If you can see objectively also, efficacy, these three are good. Safety wise, all are equally fine. So there is no drug which has a very remarkable safety profile, nor a drug which has a very adverse profile. But the suitability is again important, because it's an acute treatment. We want the therapeutic objective to be achieved as soon as possible. And also in the cost way also, it is nitrate has an edge over beta blocker and calcium channel blocker. So if you can see that clearly, our P group would be a nitrate. And so we have arrived with our knowledge of pharmacology and pharmacokinetics, that P group that would be helpful in suppressing an acute attack of angina as early as possible would be nitrate, because it is not only efficacious but is suitable also. So suitability is an important. So for example, if you're dealing with chronic condition, more than suitable, we want a cost, which becomes an important criteria. But whenever we are dealing with an acute problem, what we want to achieve is an early action. So suitability and efficacy, especially the efficacy, becomes a very important criteria, because we want to achieve that goal as early as possible, because you don't want the patient to suffer from the angina pain for longer duration, right? If the patient is, for example, of a hypertension, you can wait for a week or so for the drug effect to come. But for angina, we don't want to wait. We want the effect to come right away. Now, we have selected the P group. The P group is nitrate. Now, as we know that there are different kind of nitrate. We have glycerin nitrate, glycerin mononitrate, and dinitrates and all that. So among that group, which drug to be chosen for that particular patient, right? So again, the criteria is same. Again, you make a this inventory like this, because this is a one-time activity. Once we have done this, once we have reached, identified the group and identified the drug, this exercise is over. Then that is your personal drug that you have chosen, and you will keep prescribing it and gain more information about that particular drug, right? So again, we make an inventory, like individual, which is the drug, how efficacious it is, how safe it is, and how suitable it is. And the fourth thing would be a cost also. Now, this is the table, if I would like to say. Suppose if we have gone through we have found suitability, safety, and we have found that there are 3 drugs that are available under this group which could be used. One is the glycerol trinitrate, then is isosorbide dinitrate, and isosorbide mononitrate. Right. Now we say that how efficacious they are, suitable they are, and the cost. As we know that efficacy-wise, all 3 are good, quite efficacious. This nitrate per se is efficacious, but if there is any difference among the 3 different drugs that are there in this particular group. Now, glycerol trinitrate, we have sublingual tablet, we have spray, we have oral tablet also, transdermal patch is also there, there's ointment is also available, and then there is an injection is also available, right? Safety wise, as I know that there is no difference among these different drugs that is there, and these formulation and these drugs, they are similar side effects. Like again, the vasodilatory side effect, reflex tachycardia, headache, flushing, it is there with all 3: glycerol trinitrate, isosorbide dinitrate, or isosorbide mononitrate. Right. But the suitability, if you can say, glycerol trinitrate, we have suitable because we have the sublingual spray, and also we have sublingual tablet and also spray available with this. So sublingual tablet and spray, these are the 2 things that we vouched on for the particular, for the why we have selected this particular group. If we say that the sublingual tablet would be around 2 to 3 rupees per tablet, right, and the spray would be around 299 rupees for every 200-meter dose inhalers that are taken. And they could be oral tablets. We won't go into oral tablet and patch because this is won't be meeting our therapeutic objective. Right? Then isosorbide dinitrate, we have sublingual tablet and an oral tablet. What we want, a fast acting, its pharmacokinetics should be fast acting. So the dosage we want is that sublingual tablet. Its sublingual tablet would cost around 2.73 to 4 rupees per tablet. Right, so almost same as that, slightly more expensive, but again there is no difference in safety, there is no difference in efficacy, right? So maybe the onset of this glycerol trinitrate in fact is slightly earlier, right? But overall no difference in efficacy and no difference in safety. Suitability is also similar. We have an additional options in glycerol trinitrate, but we have sublingual tablets for both are available. The cost is slightly less for glycerol trinitrate and slightly higher for isosorbide nitrate. Not much different, but slightly. So isosorbide mononitrate, it doesn't have any sublingual tablet, so it won't serve our purpose. Right? We want immediate relief for that particular patient, so could be sublingual or the spray would be useful. So from this we can found that among the nitrate, glycerol trinitrate or isosorbide dinitrate would be the most suitable drugs. And based on the cost, if we say that maybe glycerol trinitrate, it has everything is similar, efficacy is good, safety is good, it is equally suitable as isosorbide dinitrate, then and it is less, it's cheaper also. So that's why most of us would choose tablet glycerol trinitrate as a P drug or the P medicine or a personal medicine. So based on the efficacy, safety, suitability, and also on the cost, we arrive, for example, in this case, that we feel that for such patient who has angina and we want to achieve immediate treatment or for the purpose of acute, for aborting the acute attack of angina, a tablet glycerol trinitrate 0.5 milligram sublingual would be our P drug that we would be prescribing for any patient who has come with these kind of problems, provided that this particular drug is not contraindicated. So that we have to gauge in our mind, because if this is contraindicated, again we have to choose another drug for this patient. So now coming to the summary of this particular exercise, if we can say, what we have done is that we have made a diagnosis that stable angina, that the patient that we have here is of stable angina pectoris, and what we want to achieve is we want to relieve this pain as early as possible. We make an inventory of the P group from which we feel that would be useful for the treatment. So we arrived at nitrate, beta blocker, and calcium channel blocker. These are the most efficacious groups that are there, right? And we feel that their safety is almost equal, but the suitability of nitrate appears to be much more than the beta blocker and calcium channel blocker, because beta blocker and calcium channel blocker can be given only by injection for their fast action, but the nitrate, we have sublingual tablets and sprays are also available, right? So that way nitrate becomes the most suitable and equally efficacious. So our P group would be the nitrates. So now among the nitrates, which drug? We see that they are glycerol trinitrate, isosorbide dinitrate, and mononitrate. all are equally efficacious, all have the similar safety profile, right? But in glyceryl trinitrate, if we see that it is sublingual tablet is available for the glyceryl trinitrate and isosorbide dinitrate, so they become more suitable than this. And if we see the cost wise also, the glyceryl trinitrate is much cheaper than other two formulations. So based on the efficacy, suitability, and the cost also factor, we arrived that our P drug would be glyceryl trinitrate sublingual tablet of the spray. I mean, sublingual tablet would be preferred because its cost is again lesser for the patient. So I hope you have understood this particular problem, why we have chosen for this patient, why we have prescribed this patient tablet glyceryl trinitrate 0.5 milligram sublingually. So this is how we asked him to dispense such 10 tablets. I think that should be sufficient for this patient. And then we mention certain important things in our prescription, that one tablet should be taken, and if the symptom does not evolve, it can be repeated after an interval of 5 minutes and a total of 3 doses maximum. Because after that, it could be it could not be just an angina, it could be a myocardial infarction. So this is the format of the prescription that we discussed in the last lecture. The details, particulars of the doctors, the date, patient particulars, then you have the superscription, then the body of the prescription, then subscriptions will also be there. Maybe there's a subscription, and then you have instruction to the patient, right? The signa, and then your signatures and the stamp is also there. So this is how we write a complete prescription. And then what are the information, instruction, and warning that we need to give to the patient is that how the drug is acting, very briefly about that. It relaxes your blood vessels in the heart, that's why it improves the blood flow, and any common side effect related to this, that you might have flushing and mind headache, it is common with this. The instruction how to take a sublingual tablet, how to store these tablets, if it is, you have to protect it from light, otherwise it won't be efficacious. You have to use it within 2 months when you are opening this particular bottle, because it won't be efficacious if you're using it after 8 weeks to resolve this problem, right? Then any warning that you don't have to take it beyond 3 doses, because after that you must come to emergency, seek medical attention, because it could be an irreversible ischemia, and that could be a myocardial infarction, right? You ask him whether he have understood what you have told him, and ask him to repeat. So that's how we have chosen a drug, is most suitable drug for this patient. We have prescribed it, and then we have given the relevant information and instructions. Thank you. I think this is the very brief exercise that we have done, and after this we would be having a discussion on 3 or 4 different cases, like we have done for angina. We would have made cases on hypertension and migraine and on glaucoma. So we'll be discussing and selecting a suitable drug for such patients, and using the similar logarithm that I have shown you, that how to prescribe rationally, you have to achieve a therapeutic objective, then how to select a P treatment, then the P group, and then the P drug, and then how to prescribe, and then how to communicate the relevant information to the patient.